step one. Thank you all for being here tonight. Good evening. My name is Tracy Levine, and I am the Executive Director of Healing Housing. Healing Housing is a nonprofit residential recovery program for women with limited resources here in Middle Tennessee who are healing from addiction. In addition to the extensive services that we provide our residents, we also serve as a referral resource for families and individuals seeking recovery support, as well as to provide educational outreach to our greater community. Earlier this spring, I happened upon the ABC Bob Woodruff special titled Poisoned: America's Fentanyl Crisis. I was alarmed to know that Nashville is now ranked the third highest for having the most overdose deaths in America due to fentanyl. Dr. Stephen Lloyd, our keynote speaker tonight, was interviewed extensively for this special and shared how his work on the front lines in addiction has changed due to this deadly poison. The personal stories of families who had lost their children right here in Nashville shook me to my core. Bob Woodruff interviewed families whose kids thought they had purchased prescription opiates, but instead received drugs poisoned with fentanyl, resulting in heartbreaking deaths. I know that recovery from addiction is possible. I have the honor of working with women daily, like myself, who are a living example of that. Those of us with long-term abstinence from substances agree that the landscape of experimentation and using has changed drastically, and the statistics tell the bleak reality. The gamble and the risk of losing one's life over using any drug has never been greater. I'd like to introduce you now to Cash, who is Healing Housing's treatment program coordinator, who can speak firsthand about her experience with fentanyl and the devastating impact it has had on the women that we serve.
Hello. My name is Cash, and I'm the Program Treatment Coordinator at Healing Housing. I'm grateful to be here with you tonight, and I'm also grateful to know that so many people have an interest in learning more about fentanyl poisoning in our communities. This is a topic which is especially close to my heart, not just because of the line of work that I'm in, but because of my own experience with fentanyl use. My story is not much different from the stories that are shared with me at Healing Housing by our participants. More often than not, the first time that a person is exposed to fentanyl, it is entirely unintentional, resulting in accidental overdoses. Typically, the women that we serve who regularly use fentanyl have survived double-digit overdoses. I've heard it said that opioid overdose reversal medications enable addicts to continue using, and I stand before you tonight as a testimony that this is simply not true, and that the only thing that medications like naloxone and Narcan enable is breathing. And so long as an addict is alive, there is always hope and a chance that they may also find recovery. Thank you so much for coming tonight.
Thank you, Cash. She might just have earned herself a new job. Well, with all of this heavy on my heart, I reached out to Lindsay Wilhelm, the Executive Director of Williamson County Anti-Drug Coalition, to talk about the idea of partnering to present this important topic in honor of National Recovery Awareness Month. With kids of all ages headed back to school, we both agreed that it can't be talked about too much. We are grateful you chose to be with us tonight so that we can work together to stay seated in prevention and solution and to do everything in our ability to save the loss of another life due to fentanyl. It is my honor now to introduce Michael Baer. Michael works as a regional overdose prevention specialist with the Tennessee State Department of Mental Health and Substance Abuse Services. As a specialist in this field, Michael is responsible for outreach, education, and resource distribution in Williamson, Wilson, Rutherford, Cannon, and Trousdale counties with the goal of lowering the opioid and stimulant overdose death rates in the region. This program has been in effect since 2017 and is responsible for over 44,000 confirmed overdose reversals through the distribution of the overdose drug naloxone, as well as many other life-saving overdose reversals that have not been documented. Michael provides education and training about how to be prepared to save the lives of strangers, loved ones, or those who are at risk of overdose themselves.
Good evening. So good to have you all with us tonight. Thank you so much for coming. As Tracy said, my name is Michael, and I work for the Department of Mental Health and Substance Abuse Services as a ROPES, and it is a real privilege to do so. The people that I work with, we all, do a lot of work in our specific communities to try to educate people, try to bring the communities together, and help to understand the core issues that are kind of leading the causes of all these problems in our communities. What can we do about it? How do we think about these problems that can be helpful? So with that, again, just incredibly excited to be here with you tonight to talk with you a little bit about some statistics, about a little bit of a background on the opioid epidemic, a little bit more information just about the holistic viewpoint of Tennessee in general with regard to the opioid epidemic. And I've been told that this occasionally works and sometimes doesn't, so we'll see what happens. So first, a little bit of background here in terms of the opioid epidemic and the overdose epidemic as we see it today, right? So this is not something that just happened. It's not something that has been the same way when it was kind of starting in the late 90s, and it's kind of been that way all the way through to today. What we actually see is that this has really changed over time. It has evolved quite a bit. And so what do we see in the beginning of this crisis? The issue at hand was the overprescription of opioids from doctors, hospitals, things like that, because the companies that were selling these and creating these medications were really being kind of unscrupulous about how they were marketing them. And they were basically just trying to get as many people, as many doctors, hospitals as possible to buy their product. And, that had disastrous consequences. Large swaths of the American community were given vast overprescriptions of OxyContin. Particularly, that's one of the main, really, really bad contenders there. But, others as well. Just tons of these drugs were being prescribed. You had people going in for leg, knee surgeries or back surgeries, and suddenly they were, given 90 pills out the door with 5 refills for a recovery period of 20 days or 30 days. And so you can see how these kinds of things would really become a problem over time. So lots of people became dependent upon these drugs. It does not take that long to get dependent upon a really strong and highly addictive opioid. And so when we started to see the trends to where so many folks in our communities are dying because of these overprescriptions, well, what do, right? We pull back on the amount of prescriptions that we give. That seems reasonable, right? Seems like a good idea. But as with many things, there are rules of unintended consequences, right? So as we prescribed less and less, and we pulled back and we regulated the amount of drugs that we could easily prescribe, that doctors could easily prescribe to their patients, what ended up happening is a lot of those people who were dependent upon, and in many cases addicted to these medications, for reasons that were pretty reasonable in the beginning, right? That they had that surgery, they had, maybe a chronic disease of some kind, and then all of a sudden they can't get those medications anymore because we're pulling back on those prescriptions. So what happens? They begin to look for other ways to get the medications that they're very used to, that they're dependent upon, and in some cases they are addicted to, right? And so that's where heroin comes into play. In the early 2010s, late 20aughts, early 2010s, we see heroin becoming a much bigger issue than it had been before, because suddenly those prescriptions of prescription opioids were no longer that available. So then, that only lasted for a short time before fentanyl really came onto the scene, really took over as the primary overdose death driver in our communities. And the reason for that, we'll get into it more as we go here, but as we're all aware, fentanyl is an incredibly powerful opioid drug. It's synthetic, and it is easy, relatively speaking, easy to make, easier to smuggle in a lot of cases, right? And so this is something that has become the primary driver in overdose deaths that we see in Tennessee today. So just a little bit of a graph here. I'll have a few of these for you. Everybody loves graphs, right? Who doesn't love a graph? But this is just the level of kind of the number over a period of about 8 years of the overdose deaths in Tennessee of prescription opioids, right? Relatively stable, though obviously concerning. But then what we have is in the late 20-teens, fentanyl and stimulants start to vastly outnumber the rest of the drugs on the proverbial market in terms of what is driving these opioid overdoses, what is driving these overdose deaths. Stimulants are a different class of drug than opioids, so it's not all opioid overdoses. And what we see in 2020 is this start of basically an exponential increase in the amount of deaths that are involving fentanyl here, right? And as a matter of fact, in 2020, there were about 2/3 of all overdose deaths that we saw were in fact, at least in some part, due to fentanyl, because there are some mixing of drugs in many of these overdose deaths. So this is a map of Tennessee. I have another one in a moment, but you can see kind of the darker areas that are the more harder hit in terms of just the pure numbers, which makes a lot of sense. The darker areas, very, very dark, are generally speaking major populous areas: Knoxville, Nashville, Memphis. And so, but in 2020, there were about 3,000 Tennesseans who died of a drug overdose. That is the official numbers. In many cases, we might infer that there are more than maybe the official count for one reason or another, though I wouldn't say that it's vastly more than this, right? But so it's a pretty reasonable number to work with. We had about these 3,000 plus deaths, but about 2,000 of those involved fentanyl. About 1,300 involved a stimulant. That is an 85% increase in deaths due to fentanyl based on year over year, 2019 and 2020, and about a 45% increase in deaths due to a stimulant. Right now, the stimulant that kind of is doing the most damage, it feels like, is methamphetamine. A lot of times fentanyl and methamphetamine are mixed quite a lot. That happens a good bit. So in Williamson County specifically, there were about 30 drug overdose deaths in 2020. These are the latest yearly numbers that we have. Hopefully, in very short order, we should be getting the 2021 numbers. At the moment, we are still working with 2020 numbers. So 30 overdose deaths, again, officially are in the Williamson County area. There were about 22 of those were fentanyl related, right? So this is kind of following that same statistic that, about 2/3 of these are involving fentanyl in general, whether that's blown out to the state or even into the more smaller county level. So this is just one more map here to show you those fatal overdoses due to fentanyl across the state, right? So we see, again, obviously the large population areas are going to have the most fentanyl overdose deaths, but this is a problem that exists all over the state. It's easy to understand why lower population counties are going to have less, but it really does cut across county lines, cut across, cities, across areas. This is a problem that is not going away, and it doesn't really care who you are or where you live. It is definitely concerning for a lot of folks in every part of our state. And so we are just wanting to really bring the education about how prevalent this is and about how powerful this drug is, right? So let's talk a little bit about some risk factors here for an overdose. And this is not specific to fentanyl. This is kind of across those lines of opioids. So what is this, hydrocodone? Is it OxyContin? Whether maybe that's prescribed or illicit drugs like heroin or fentanyl, it kind of applies to all of these kinds of, this whole class of drug, right? So mixing drugs is certainly a concern. Mixing, opioids with, a stimulant or alcohol. These are things that can easily create that cocktail effect that have sort of it's a greater than the sum of its parts sort of thing. And it's definitely something that is people who do that are certainly at a much higher risk of overdose. Also, a period of no use is really a very, very significant factor in whether or not somebody who is, maybe one person, two people are both using illicit drugs, right? One of them has gone through a period of no use, one of them hasn't. That person is much more likely, right? Because if they've been through, maybe they've been in jail for a couple of years, or they have been to an intensive rehab, or if they've been in recovery for a long time, they no longer have the tolerance that they used to have. But people don't really think about that when they're going back to, a drug that they've been off for a while. They don't really think about that. They're more likely to use the amount of drug that they remember using, right? And so that leads to people who had a higher likelihood for overdose because their bodies can no longer handle what they remember being able to take, right? Huge one here, counterfeit pills. We'll talk more about this in a moment, but fentanyl is in so many kinds of pills that you are, if you are a buyer on the illicit market and you're going to someone and saying, I would like an Adderall, or I would like a Xanax or a Valium, or a hydrocodone, anything, it is definitely within the realm of possibility that what you're buying is actually just fentanyl, or fentanyl mixed with something in some way. This is it is part of the fentanyl epidemic that we see, is just that this is why we say fentanyl poisoning, right? It's maybe, you maybe not be able to say that it's fentanyl poisoning if somebody's actively looking for fentanyl, but the fentanyl poisoning is because people aren't looking for it, and that's what's in the drugs that they're buying, right? There are other things as well that certainly play into likelihood of overdose. That could be anything like a serious mental health condition, or a history of other kinds of substance misuse, chronic illness, suicidal thoughts. Another big one, using while alone. I hear this all the time from folks who are in these communities, is that, my friend, he passed away because he was alone, and they found him days later. Well, if you're alone, and then no one, even if you had something that was going to help you, you wouldn't be able to use it because you're by yourself and you're unconscious. So these are just kind of things to keep in mind as well about kind of the risk factors involved. So let's talk a little bit about what opioids are doing when when you take them. What are they doing to you? Well, what they do is they deliver a significant amount of dopamine to your brain. Dopamine is that happiness chemical. It's what makes, all of us tick in one way or another. When you get that, that donut in the morning or whatever, you hug your loved ones. What's going on in your brain is that you're getting dopamine to your brain. Your brain is sending you chemicals that say this is a good thing, right? So opioids give us that same chemical, but it gives us a huge, huge hit of it externally. It's not because we're doing something that's good for us. It's because it's delivering it to our brain in mass. So it does that by sitting onto these receptors in our brain, these receptors called opioid receptors, right? And when they do that, they deliver that chemical, but they also give a message to our brain and to our respiratory system. And that message is slow down, slow down. So it's called the depressant, right? Because our respiratory system is being depressed, it's being pushed down. And what happens when you take too much of this is that, eventually your heart stops and you stop breathing. And that is really what the mechanic that's at play when we're talking about opioid overdoses, is that their heart stops, their body is being told to shut down. It's nothing that's really wrong with your body, it's just that it's being told to shut down from a top-down perspective. Now, something else that I'll talk about really quickly here, because I don't think I have another slide for it, is there are large amounts of people within our communities certain populations who have a much higher likelihood of when they feel that dopamine hit for the first time, that their brain is latched onto it. That they say, that is what I've always wanted, and I've never been able to get enough of it. One of the things that we talk about a lot is called ACEs, or adverse childhood experiences. And so if somebody has been through experiences like neglect as a child or abuse, maybe somebody in the household has been abusing drugs or alcohol, and it's maybe somebody has been in jail, one parent household kind of thing, anything like that, these are all adverse, negative, right, experiences that as a child, their brain is developing, their brain is sort of building the pathways they're going to be using for the rest of their life. And so when a child grows up in those circumstances, it is incredibly harmful. And what happens is the people that are growing up that way, they live a lot more out of their sort of lizard brain, sort of a fight or flight, survival of the day kind of brain, kind of chemistry. And they don't have enough dopamine as it is. Somebody who grows up that way, their brain is not going to create the dopamine that somebody who didn't grow up that way is going to create. So if somebody like that experiences that huge rush of dopamine, that big hit, what's going to happen? They are so much more likely. I'm not going to say that everybody does that, right? It's still a spectrum, but the statistics tell us that people like that are so much more likely to immediately latch on, for their brain to tell them, that's it, that's the thing, that's what you've always wanted, and you've never been able to get it, and now you know how to get it. That's how. We're going to keep doing that from now on, right? There we go. So this is just a little bit of a kind of a slide here to show you visually how strong fentanyl is as opposed to a more kind of traditional illicit opioid like heroin, right? Heroin, you can see in this kind of vial here, that's a drug that it's reasonable to assume that somebody who knew what they were doing would be able to dose that properly for themselves and not take too much. Now, when you're getting into fentanyl, which is about 50 times stronger than heroin is, and then you get into carfentanil, which is a fentanyl analog, it's kind of a similar drug, kind of made a little differently, you're talking about almost 4,000 times stronger than heroin. So these are drugs that so little of it, when taken straight into the bloodstream, can be catastrophic. It's almost impossible to dose appropriately, almost impossible to dose effectively outside of having a pharmacist put it into a bag that's parts per million or into a patch that is going to slow release through your skin. That's really the only way that it's safe to use, and it's safe to use because that's how it was designed. It was designed for end-of-life care, for cancer patients, things of that nature that need very, very strong pain medicine, pain control, right? That's how it was designed. That's why it is how it is. But when we're using it illicitly, it becomes so, so dangerous. And you start to think about, well, yeah, this makes sense. We've got this much flour. We've got this amount of fentanyl. That checks out. But what happens is you start to mix that together, and it's not equal parts. You can't. The people that are doing this are not dosing it appropriately, because it's incredibly hard to do so because of how powerful it is. So how is fentanyl, how is it being sold, right? It's being sold in lots of ways. It's being put into powders, maybe dropped onto blotter paper in kind of edible form, nasal sprays and eyedroppers in some cases. Although, one of the main things that we see is mostly in either powder or in pills that look like real prescription opioids. This is something that, is one of the main reasons that we're here today, is because, again, fentanyl poisoning, right? Those two sets of pills look so similar. The pill presses that they're able to create or buy, they make them look so real and so genuine that no one is going to be able to tell the difference between these pills. It's very, very difficult to do. I doubt a pharmacist at first glance would be able to tell, right? This is not something that you can just see or smell. It's something that is kind of insidious in how untraceable it is. Now, when speaking of untraceability, right, what can we do about it? There's got to be something. Well, one of the main things that we're really excited about now is the ability to have fentanyl test strips. These were actually not legal until relatively recently. They were considered drug paraphernalia. Now they have been legalized. You can buy them on Amazon. Our program is about to be able to have them to give to people, which is amazing. We're very excited about that. But what they're able to do is actually detect when fentanyl is in a powder or a pill. If you crush it up and you dissolve it into a little bit of water, you can use these fentanyl test strips to actually detect what's in there and see if it's, what they say it is, or at the very least see if there is fentanyl in what they sold you, right? It's a little like a COVID test where you're looking for lines, but it's kind of switched where if you were to use this, one line is sort of the positive, yes, there's fentanyl in it, and 2 lines is a negative test. That means there's not fentanyl in it, right? So a little bit different there from what we've been used to over the last couple of years with COVID tests, but we're, again, very, very excited to be able to have that as a tool in the toolkit to start to bring some transparency to what is it that we have here, what is being sold. So these test strips, they do cost about $1 per strip. They have a significant accuracy, 96 to 100% accurately detects the presence of fentanyl. And most of them can detect at least 10 analogs. An analog, like carfentanil, is an analog of fentanyl. They're basically the same thing, just varying chemical combinations of the same thing. They're so wonderful to have. They are going to allow people to just be a lot more knowledgeable about what they are taking. And a lot of people who are engaged with kind of harm reduction services, like syringe service programs, for instance, has said that if they had them and they used them often, that they would lower their own use over time. It would affect, knowing what they were taking might and probably would lower their use over time. They would have to adjust based on this new information, which is a good thing. We're always wanting people in those situations to be more careful about what they're doing and to eventually, over time, right, to get into recovery and to stop altogether. So some signs and symptoms of an overdose, what does that look like, right? Well, as long as somebody can respond, if somebody is sort of sleepy and they're kind of nodding in and out of consciousness, it's something like that, but they can respond to you, they're talking to you, that is a good sign. What we're looking for in an overdose is essentially that somebody is unable to respond, they are completely unconscious, and as a matter of fact, their breathing and their respiratory system is going into shutdown. And what does that look like, right? That looks like a pale face, maybe purple or blue face if it's getting really bad. Maybe it's blue lips and fingernails. That might, lead to you to understand that they're not getting enough oxygen. Heartbeat may be irregular or really slow or non-existent. And really the biggest thing here is, vomiting as well, involuntary vomiting, while they're unconscious. These are things that we're definitely going to be looking for. Those are the real overdose symptoms, is that total unresponsiveness. So also, as I said earlier, there are absolutely overdoses that involve multiple substances. So methamphetamine and fentanyl, or cocaine and heroin. These are things that often are put together. They are often, maybe not even known, unbeknownst to the people that are, again, buying them, right? That they are something other than what they thought or whatever. Maybe you want that. That's some people do. And so in Tennessee, about 1 in 3 fatal overdose deaths were caused by both an opioid and a stimulant, so some kind of mixture of those things. Now, what's a little bit frustrating about stimulants is that there is no drug, there is no cure, so to speak, to a stimulant overdose the way that there is to an opioid overdose. So you can't really do a lot in terms of giving them a medication to help them out of a stimulant overdose. But you can always provide naloxone or Narcan, and whatever is involved that is opioid related will be alleviated, right? That will help that piece of the puzzle of what's going on. And that will oftentimes in and of itself be enough that, maybe they will be okay, that they can ride out what's going on with the stimulant. So how do we talk about this? How do we broach the subject in our homes, with our kids, with our peers? This is a really serious question that we need to think about, because there's so much stigma that is attached to this issue. There are so many, culturally speaking, for many, many, many years, drug use has been so demonized that, and in some cases overblown over the course of history, that it's kind of all over the place. What is the reality of is it okay to take this drug? Is marijuana really like a Schedule I drug? Really? Is that, there's so much kind of confusion culturally, especially among young people, about what is acceptable, whatever. So it's important to think about this, right? How do we talk about it? I want to offer just a few thoughts on this. This is not business as usual. Where we are today is not where we were 5 years ago, and it's not where we were 10 years ago, and it's not where we were 20 years ago. This is a very unique situation that we find ourselves in. Kids using drugs is an old story. Parent says, it's bad for you. Kid says, I don't care, I'm going to do it anyway. This is kind of a story, tale as old as time here. That's not where we are today. We need to be clear with our kids, especially with our young people, right? That this is not business as usual. Where we find ourselves and where they find themselves growing up is a uniquely dangerous time to be experimenting with drugs that you are buying illicitly. Because anything that you buy, no matter what they say it is, could easily have fentanyl. And I hear all the time stories of parents or of siblings or whatever, family members, friends, who say, that I just heard, know somebody who was just looking for an Adderall or looking for this or that, and then they passed away because it was just fentanyl. That is something that we hear almost constantly. So that's something that I think we need to start with, is that we need to be frank and candid, I know that you want to test the boundaries. I know that you want to be your own person. I know you want to see what the world is like, but this is for your own safety. You need to be careful, and you need to be aware of the dangers of this. Many people have died due to fentanyl poisoning on their first time trying illicit drugs, like I said. Sorry, I'm just kind of rolling back here on these points. Right, no one is trying to ruin their fun, right? This is something that I think is really critical to understand, is just these frank discussions with kids, that this is not about ruining their fun, and it's not about being overbearing. This is about their safety. This is about their safety. How do we make sure that you are being safe in the choices that you're making in your young life? And then becoming a kind of a partner with your kids in taking care of their lives, being a partner with your kids and educating the people around them as well. Some of the coalitions that I work with are really doing great things in terms of creating youth coalitions where kids in their schools are advancing these issues with their peers, because they get it, that this is a really dangerous thing, that they don't want to see their friends die because they were goofing around and they were taking something they didn't know about. So that's the kind of thing that we need to be having those open and honest conversations about where we're at and how to keep them safe, how to make sure they are being as absolutely as safe as possible. Now, let's talk about responding to an overdose, right? We know about it now. We are understanding the problem, a lot of the ins and outs of it. So let's assess the situation, and let's assess our personal safety in this situation, right? So is this person responsive? Can they communicate? If they can communicate and they are responsive, that's great. That's the first sign that they're going to be, or at least at the moment, are doing okay, that they are responsive, they're talking to you. If they cannot respond, if they are unconscious, and there's other signs as well, right? Maybe of whatever stripe. That's kind of when we need to think about stepping in, okay? Now, a lot of people, there have been so many stories, news stories about, maybe this guy just was around fentanyl and he passed out and stuff like that. And so we need to talk about that too, your personal safety. How do we work that into this as well? So in terms of maintaining our personal safety, fentanyl is not something that is incredibly dangerous to you by being around it. Our skin is a magnificent barrier that does not allow a lot through it, and it is wonderful at protecting you from things like that. It's not small enough to get through your skin. So, and it's also a pretty heavy substance in general. So it's not, unless somebody just threw it up into the air, it's not going to be in the air either, right? Even if it was in powder form. The main point here is don't be afraid to kind of get into a situation if that is your concern. That's like, I don't even want to be near it because I've heard that it's like that powerful. It's very, very powerful, but unless you are ingesting it in some way, putting it into your mouth, nose, eyes, it's really quite safe to respond to, right? And we always give out gloves in our kits. If you have gloves and you're in that situation, wear them. And if you don't, go wash your hands as soon as possible afterward, because we can always put our hands in our eyes without thinking about it, whatever. So that's something to be aware of, certainly, but it's not going to affect you immediately. A lot of the time when people say that it does, what's actually happening is that people are getting very anxious. They're having panic attacks because they know they're worried, right? And that's kind of what that is going on there when they're having reactions just by being around it. So administering naloxone is the only real way to get into and to reverse an opioid overdose, right? It's something that actually happens because the opioids, it actually gets at the root of the problem. This drug actively kicks off the opioids from where they're sitting on your brain, on these receptors, and it sticks in their place, and it acts as a bit of a blocker. It acts as a blocker so that opioid can no longer touch and affect your brain. It doesn't get rid of it, it doesn't kill it, it just makes it so that it can no longer affect the person involved, right? We can do this. Naloxone, so it reverses the effects by binding those receptors more powerfully, like I said, and then it only lasts for about 30 to 90 minutes. That's a big part of it because a lot of opioids last for a lot longer than that. These last for 30 to 90 minutes. That's the efficacy period of naloxone. So we need to be aware that secondary overdoses are possible, right? That where if they just took fentanyl and boom, they're out, and then you're giving them naloxone, that it's possible that opioid is going to be effective after an hour and a half. And then that wears off, and then the opioid comes back down, and it sits onto that receptor again, and it touches them and affects them again. So that's why we need to make sure we are calling 911 as well. I'll get to those logistics in a moment. Also, naloxone does result in people who are active users, who are dependent upon and perhaps addicted to opioids. They are going to be in withdrawals because it's not because of the naloxone, that drug is harmless, but because they can no longer feel any opioid going into their brain, any effect of that's going to bring them out of it right away, and it's going to, they're going to wake up in withdrawals, which is, a dangerous place for them to be, but it's a lot safer than letting it happen to them and not giving them naloxone. Lastly here, it's not possible to overdose on naloxone. Naloxone is a harmless drug. It is very good at one thing, and this is what it does. So if somebody was using it, or a kid could spray it accidentally and sniff it, whatever, and it would not have negative effects, right? Harmless drug. So there are a lot of different kinds of naloxone. There are nasal sprays, pre-loaded nasal sprays, atomizers that are given as well through the nose. Intramusculars as well that are auto-injector or in a vial. These are all different versions of the drug naloxone. Narcan is a brand name of that drug, so it's not like they're two different things. Kloxxado is a new one that we give out a lot. It's a stronger dose to people like first responders. If you were ever going to inject it, a great place to inject it would be the outer thigh because there's a lot of muscle there, easy to get to, things like that. We recommend the nasal sprays. They're very, very easy to use, incredibly simple, and highly effective. So let's talk about, again, responding to this overdose, right? Number one, we're going to try to maintain that responsiveness. If they can talk to you, that is great. We're going to try to keep doing that. One of the ways that we hope that people do that is by providing a sternum rub. So we're going to take the kind of joints of our fingers and kind of rake them real hard across the sternum because that is going to provide some discomfort and pain. If you do it yourself, you can tell it's kind of like, it sort of hurts a little bit. You can tell how it could really hurt. So but it's not going to do any damage, right? If you're like shaking them and whatever, like you might hurt their neck, whatever. There's things like that punch them as hard as you can. Like, don't do that, right? So, so that's something that we do. And if they are not responsive, they're not with you at all, that's when we're going to move on and start thinking about naloxone. If you have that naloxone, that Narcan, we suggest, the PPP, peel, place, press method. It's very easy. They each come in a little blister package. You peel it out. You place that bad boy as far up the nose as it will go, and you press the button, and it's pressurized. So as soon as you hit that button, the whole dose is going to be expelled, and that's going to go up into their nose, up into their glands, and up into their brain, and that will, any EMS person or firefighter, police officer will tell you, it works real quick. Ma'am, I would love to, ask your question. So if you are not breathing at all and there's no blood flow at all in your body, somebody smarter than me would have to answer that question. But usually what's going on is there's at least a little bit of blood flow, and it's able to kind of push through the glands and into the brain with a little bit of that blood flow. This stuff works for a long time. People talk all the time about how officers and firefighters refer to people as they were dead, right? That's kind of how it looks and how it seems, and it still does work. So definitely worth a try at the very least. Next, we're going to dial 911. This is kind of feels like a no-brainer, but please dial 911 if you're in this situation. They're going to offer a lot of perspective and help for you in the moment, as well as getting them there is really, really key, because that naloxone is only a bit of a Band-Aid, right? It only works for that 30 to 90-minute period, so we need to make sure they are there, they're arriving in time to catch that maybe secondary overdose, and they're going to be in withdrawals, right? So they can treat those symptoms, like maybe somebody is vomiting or whatever, maybe they are in full body pain and aches and stuff. EMS can treat those symptoms in a way that you certainly can't as somebody who doesn't have those kind of medical supplies or training. Next, this is a little bit kind of yes and no here. A lot of times, this is not really necessary. CPR is not something that is always necessary. It can be necessary if people are, if they have a serious heart condition or they've had a stroke or open heart surgery, things like that. This is something that can be necessary, but often is not. And so people will just kind of come out of it and not really require CPR. But knowing that it might be necessary is certainly something that we want to let people know. And probably 911 will walk you through that. If you are not talking to 911 and you are not trained on how to do CPR, I wouldn't recommend it. But it's something that we like to explain to people that it might be necessary. The next thing is we're going to place them in the recovery position, right? So far we've checked, are they responsive? No. Okay. Give them naloxone. Great. Now they're kind of coming back to consciousness. That's great. We've dialed 911. Okay. Well, while they're coming back to consciousness, they are very likely to be vomiting in a big way, because vomiting is one of the main symptoms of withdrawal. And they're obviously going to be in withdrawal. So making sure that vomit has a place to go that isn't just sitting in their throat is a very important thing. So put them on their left side as much as possible with their airway open and their head tilted down, and that is going to allow that vomit as it comes out, as not nice as it is to think about, it's going to allow it a place to go. So if they're on their back and they're kind of vomiting a lot, it's really easy to see how they could just choke on that vomit, right? So we need to make sure that as they're doing that, it gets out of their system. And that they're safe from that kind of choking hazard. Next, we're really just going to stay with them, tell them what's happened, because they will not know really automatically what's going on. Kind of be a calming presence if you can. If you don't know this person, listen, you can take some steps. I would encourage you to maybe give them some space, because this is going to be a tough moment. But you're going to have information that they don't, right? They may not know that if they take more drugs, that they're not going to feel better. As soon as somebody's in withdrawals, the first thing that they're going to want to do is try to take more, because that's the last place that anybody who is dependent upon opioids wants to be is in withdrawals, right? That they fight a lot to try to keep away from withdrawals. So they're going to want to take more of that drug as soon as possible. you're going to have the information that if they do that, it's not going to help them feel any better, and they're doubling the dose of whatever's already on their brain that made them overdose. So that's information that is very key to let them know, and to let them know that, listen, 911's on the way. They're going to be able to help you with this. They're going to be able to help you with this in a way that taking more of that drug is not going to be able to do. Oops. Yeah, and then lastly, just inform the paramedics when they arrive of whatever's happened. Again, you kind of have the gist of what's been going on. How much of this did they take? I don't know, or this much. How much Narcan did you give them? These are all things that are going to be helpful for EMS to know in those situations. Yeah, this is kind of rehashing some of what I've already said. Some of these withdrawal symptoms, right, they might be erratic. They might, in some rare cases, they might be violent. So again, taking that space, if you don't know that person, is a good idea. Projectile vomiting, maybe that cardiovascular event if they have some kind of issue, right, as I already said, and massive amounts of musculoskeletal pain. These are all things that are absolutely in the cards for somebody who has been given Narcan, not because of the Narcan, again, but because of the withdrawal that they're in, because of it. So kind of wrapping up here, I want to talk a little bit about the laws in place. There's a law that is called the Tennessee Addiction Treatment Act. That law says that anybody who is seeking medical attention for their first overdose is free of prosecution for that drug offense. This is basically to try to get people, help if they need it so that they're not afraid to seek help for them or somebody else that they're with if there's an overdose. We want to make sure that those people are call 911. Yes, do it. We're here. We're trying to help save lives, right? Not worry about whether or not you're going to be prosecuted for drug offense. Also, the thing that's really important for us here is that the Tennessee Good Samaritan Act says that anybody who is trained and who has education on Narcan and who carries it and in good faith administers it to somebody that they think is having an overdose, they are free of civil liability in this situation. They're going to be nobody can sue you or get mad at you and threaten legal, whatever, because you put them into withdrawals and they didn't like that or whatever. You are free of civil liability in these issues because of that. Here, whoop. Let's see if it can work. Let's go. I believe in you. Lastly here, Narcan is widely available at pharmacies. Any local pharmacy is going to have it, and you can buy it. You can purchase it without a prescription. There's a standing order in Tennessee that says that nobody needs a prescription to get this. Now, our program exists to provide Narcan for, naloxone in general for people who are at high risk and need it, people who maybe they don't have insurance and don't, have the money to spend $100 or $150 on a drug from the drugstore. So that's a big part of why we exist, as well as educating people to provide that resource, that vital life-saving resource to people. And so we do have Narcan available today. Be happy to talk about that with you out in the lobby later. Now, what are some things that we can do in our community, right? How can we help? Because everybody here, it seems like we're all in the same boat of how can we help? What can we do about this? We need to talk about it more. So I'm not going to talk about all these, but we can, having that naloxone available if you have any reason to believe that you might need it. Raising awareness in your community, talking to your kids, talking to the people, that are around you at your workplace or whatever. Scheduling a training with somebody like myself or, other people that do what I do, right? Knowing where to find those recovery resources in your community, supporting people who are in this recovery journey. It's, there's a lot of different ways that we can educate ourselves, continue to educate ourselves, be resources in our community, dig into other, groups and organizations that are trying to do good things about it. One such organization is the Williamson County Anti-Drug Coalition, which is doing great work. Lindsay Wilhelm, who is co-hosting this event tonight, does great work, and we're building up our resources as a community through that organization, and hope for lots of community engagement as we go and as we move forward with that. And also, there are places where you can dispose of unwanted medications. This is a little bit unrelated, but we do like to say that, getting rid of old medications, especially if they're opioid medications and you're not using them, is a big deal. It's a good thing because a lot of times kids can get into, people can get into your medicine cabinet. So locking it up or disposing of it if you're not using it is a great thing. We also have lock boxes, by the way, outside for free. If anybody would like a lock box so that, I have a prescription medication, I'd like to keep it under lock and key, we have that for you. And guys, that is essentially all I have for you tonight. Thank you so much for lending me the time, and it's a pleasure to be with you. Thank you so much.
Well, thank you so much, Michael. That was a truly wonderful and informative presentation that you gave, so thank you very much. And good evening to everyone. Thank you so much for taking time out of your evening to come sit with us and to hear all of this important information that is impacting our youth, our young adults, and, as you've heard, everyone in our community. So, that's okay. My name is Lindsay Wilhelm, and I'm the director of the Williamson County Anti-Drug Coalition. Our coalition works to inform and implement strategies that prevent substance misuse among youth in our community. Our focus areas are prescription drugs, including stimulants and opioids, like you've heard tonight, underage drinking, marijuana, and tobacco, all forms of that, traditional cigarettes, electronic cigarettes, vaping, and then we also focus on mental health and stress management. We offer a variety of services, including youth and adult substance misuse presentations, health fairs, community events, and even sporting events. Then, as you've seen this evening, we offer harm reduction and naloxone training. I was told a quote the other day that really stuck with me because it's true to our work and to the work everyone does here. We meet people where they are, but we don't leave them there. This certainly goes for our keynote speaker, Dr. Stephen Lloyd. Dr. Lloyd has decades of experience in internal medicine, mental health, substance abuse services. He is the current medical director for Cedar Recovery, an outpatient addiction clinic with 4 facilities surrounding Nashville. His background includes serving as the medical director and assistant commissioner for substance abuse services with the Tennessee Department of Mental Health and Substance Abuse Services. Dr. Lloyd has himself been in recovery since 2004. Experiencing addiction firsthand has allowed him to develop a unique approach to patient care that is passionate, effective, and impactful. His daily goal is to help as many people receive the quality treatment they deserve in order for them to feel better, get better, and stay better. So it's my honor now to introduce to you all Dr. Stephen Lloyd.
All right. Unlike Michael, I am not going to be able to stand here. Not going to happen. I'm really worried about falling off of this thing. And I'm sober, so. That'll work. Is that it? Okay, thank you. I always get nervous when people introduce me. There's a long list of stuff that doesn't matter at all. It doesn't. My main criteria for being up here tonight is I earned my seat in the room. I know what it's like to be dope sick, and that's about all I need. I understand what it's like to be desperate enough to think if I don't have this thing out here, I'm going to die, and I'll do anything to get it. And I've been there, and I'm not there today, but there's a lot of people that still are. And so Michael did a great job. I don't know what I'm supposed to talk about. I got 40 minutes, and I'm like, okay, I'm going to have to start making stuff up. But I'm gonna shift it. And I just saw a couple of people in the audience I recognized, so sorry about that. It caught me off guard. I wasn't expecting to see them here. Liz and Yarnell, hello. I'm gonna talk a little bit about the system of care right now. Seeing Liz and Yarnell reminds me of some of my past life and some of the work that I do currently. We're in Williamson County, Tennessee. This is the most affluent county in the state, and everybody was sitting at the red light out here before, as I was coming in. Everybody in the whole damn county, evidently, and they were all in really nice cars. And it is the most affluent county in the state of Tennessee, yet we have a group of parents in this county that have all lost their kids to overdoses. The disease of addiction knows no boundaries. I'm a doctor. I was just as addicted as the person who is unfortunate enough to not have a home. There's no difference. I work in the jail program in East Tennessee. Every first and third Thursday of the month, I'm in Jefferson County, Tennessee, and I have our inmates on E-Block. I'm trying to learn my jail lingo. I'm a pretty bad jail lingo guy. On E-Block, and I have them for 2 hours. And every day that I come out of there, and I love those guys, they're awesome guys, I realize the difference between them and me is like this big. I got a few breaks that they didn't get, and then for the most part, they're kids. They're old enough to be my sons. And so I've been given some opportunities. So it leads me into what I want to talk about tonight, which is the systems of care. All right, because Michael did a great job of talking about addiction. He did a wonderful job of talking about opioid receptors and the medications we use to treat it and how Narcan works. He did a fantastic job. And so I'm not gonna rehash that. I'm gonna talk a little. I'm gonna expand on a couple of things he said, and it's gonna be around fentanyl. So I'm going to tell you this. Michael said if you're buying drugs off the street right now, there's a good chance that you're going to get a hold of fentanyl. And I disagree, Michael. It's 100%. If you buy it long enough, you're going to get fentanyl, guarantee it. Because the drugs I see on the street are almost all fentanyl. They're almost never heroin. I get patients all the time that, the parents call me and say, we found this and, they've overdosed and we got them back and, they had this heroin. And so I send it to the lab. It's 100% fentanyl. It's not heroin. And so if you're buying things off the street, if you're buying pills off the street, if you're buying methamphetamine off the street, if you're buying anything off the street right now, and you buy it long enough, you are going to get fentanyl. It's 100%. It's not an if. Okay, it is an absolute. And the difference is that my drug of choice was OxyContin. So OxyContin's parent compound is oxycodone. Oxycodone is 1.5 morphine equivalent, okay? So that means that 1 milligram of oxycodone equals 1.5 milligrams of morphine. So it's a way to standardize the dose of opioid based on whatever the drug is. Opana is even higher, methadone's even higher. So if you buy a 10 milligram oxycodone off the street, a Percocet, a school bus, whatever you want to call it, okay, that's 10 milligrams of oxycodone. That's 15 morphine equivalents. If you get a hold of that same oxycodone in the Percocet tablet, it looks just like it. And Michael's right, I can't even tell the difference in them. And I promise you, I got a PhD in it, and I can't tell the difference. You don't stand a chance. I promise you that. So if you get a hold of one that's got carfentanil in it, it's 100 to 10,000 morphine equivalents, and you die. Okay? And that's what people don't understand. So I think even a lot of doctors in your community here, when they hear fentanyl on the radio or they hear fentanyl and see fentanyl in the newspaper, I promise you most of them don't make the connection that this is not fentanyl that's coming out of your hospital. Okay, they're going to think, okay, these are patches that we use on cancer patients or lollipops or sprays that we use on people who with severe pain. Guys, it's not that. It's powder fentanyl made in China. Okay, brought into the United States through Canada and Mexico. I'm not a border guy, right? It's just getting into the country that way. And it's pressed into pills that look just like what our folks are taking out of the pharmacies. And I read an article this past week that actually showed some that were seized along the border that look like Skittles. All right, so the traffickers make it look like kids' candy. And so that's a really scary proposition. And I told the folks who asked me here tonight that some of the things I wanted to talk about. I am an abstinence-based guy in recovery for 18 years. The 12 steps of AA and NA saved my life, okay? They just did. But I get really, really irritated at some AA and NA groups around, okay? Because they have these young kids coming in, and these kids are struggling with opioids, and they're struggling with drugs like Opana and fentanyl, and they tell them, well, you need to find your bottom. That's bull crap. Sorry about said it. It's bull because some of these kids' bottom is death. And I actually heard a guy on stage give me this old AA line. I hate this line. Others died so that they may live. I wanted to drag him off the stage and kick the shit out of him. All right. How does the mom feel sitting on the second row knowing her kid died and you say something like that? That's the kind of language, guys, that's got to go away because we ain't dealing with alcohol. And I'm not saying alcohol's not hard. It's very hard. Still, the hardest thing I deal with is that, true alcoholic, right? That's the hardest thing I have to deal with. But the truth of the matter is tonight, Tuesday night? I can't lose track of my time. It's Tuesday night. I'm more than 21 years old. I've got an ID to prove it. I've got money in my pocket. If I want to have alcohol on the way home tonight, I can. None of y'all can stop me. All right? And if I drink really hard for the next 30 years, I'm 55 and healthy otherwise, I think. It'll take 30 years of hard drinking to kill me. It will, okay? If I stop and get a hold of the wrong pill, I'm dead tonight. This is a different ballgame. This is different than when I started doing this in 2007. I got interested in addiction medicine because of my own addiction. I started off with 2.5 milligrams of hydrocodone, and within 4 years, I was taking 500 milligrams of OxyContin a day and chasing it with about 8 milligrams of Xanax. And I did it every day, working in the hospital, taking care of your loved ones. I'm an internist, so I was working in the ICU, medical step-down units. I did it every single day, every day, right? And I wasn't in trouble. I wasn't in trouble with the DEA. I wasn't in trouble with anybody. So I promise you that there are folks out there like me who are right in front of you with pretty bad addiction. Now, eventually went downhill from there, and we'll talk about that a little bit as I go through my slides. But this is different. I got interested in addiction when I got out of treatment because I got world-class treatment. So what I'm going to talk to you today about is the difference in treatment that you get if you're somebody like me, it's got MD after their name, or if you're somebody like everybody else, because it's different, and it's what we got to correct. Okay, and I'm going to show you that. So I got help in 2004. I'm a Northeast Tennessee boy. Jonesboro, Tennessee is my hometown. East Tennessee. So I know people think that East Tennessee ends in Knoxville. It does not. You can go an hour and a half east of Knoxville, and you got the Tri-Cities up there: Bristol, Johnson City, Kingsport. Right, and I'm from Jonesboro, Tennessee. And so I got recovery here in Nashville in 2000 and 2004. A guy named Chip Dodd out near Grassmere saved my life. I will tell you this: as I walked into the treatment center, I'm like any good person with addiction going to a treatment center. I went in high, of course, and I had 2 pockets full of OxyContin, and I realized I probably shouldn't take those into the treatment center. And so I took them over to the treatment center, was right there at Grassmere where the zoo is. And so I went over to the edge where the chain link fence is, and the gorillas were just right over there, about right where this lady's sitting. So I just threw them a handful of OxyContin. So if you're ever at the zoo and you see some, gorillas that look a little shaky, it's my fault. So I got rid of my last pills there in 2004. That was the last time I ever put a drug in my body. And when I got out, I realized that in medical school and residency, we didn't learn anything at all about addiction. Nothing. We didn't learn anything about the proper prescribing of controlled substances for acute and chronic pain. So your doctor, when you have surgery, you have your gallbladder taken out, you have your knee fixed, whatever it is, and your doctor writes a prescription for you. At the end of that, how do they know which medication to pick, for what strength, for how long? How do they know that? I just told you they don't learn anything about how they know that. They use something called the SWAG method. You know what the SWAG method is? Scientific wild-ass guess. Okay. So the truth is they don't know. So if they don't know, who taught them? Drug companies taught them, right? So there's a Hulu series called Dope Sick. It is outstanding. I'll put in a shameless plug for it here in a little bit. But Dope Sick tells the story of the Sacklers and the drug OxyContin and how it was promoted. So if you want to know who taught doctors basically how to use the drug, it was the pharmaceutical industry. And it got us in a big mess, and one that I think, in my opinion, is the crime of the century. I don't know of anything that's killed more people than this, and I certainly have lost a lot of friends to it myself. So I want to talk to you today about the treatment system itself. And I started to get on AA and NA there a little bit. I'm not getting on them as a group. Okay, those are great things, but they're support groups. They're not treatment. Bill W. was the founder of AA back in the 1930s, and he never meant it to be treatment or dogma, and it's become both. Okay, it's not. Treating people for addiction has to do with getting at the underlying drivers of addiction, which in most cases, and most people in this room will know this is true, it's dealing with underlying trauma. And we're going to talk about that in just a little bit. So it's a really good thing. So I see these kids dragging themselves into the rooms, and I see some old timer in the back say, "Oh, we're here to talk about alcohol, not drugs," and I want to look in his medicine cabinet. I mean, that's the first thing I want to do. That's the mean part of me. But the thing is I'm sorry, I still got some stuff I'm working on. But the truth is that when we get these kids doing this, right, we need to, the 3 rules for my doctors that I hire. I said, you got to do these 3 things. If you can do these 3 things, I can teach you everything else. If you can't do these 3 things, you can't work here. Number 1, we got to love people unconditionally. No matter what, I don't care where they've been, I don't care what they've done. There are consequences, and we'll deal with them. We got to love them unconditionally. The next thing we got to do is we got to forgive habitually. There's nobody in this room that's perfect, and a bunch of people in this room got stuff they don't want anybody else to know, and you need forgiveness. And then the last thing we're going to do is we're going to demonstrate mercy. I get people tell me all the time, so how many chances does somebody get? I don't know. How many they need? How many they need? So when you come into a treatment center, most treatment centers around the country, and you do well for a little while, and suddenly you relapse. Maybe you get your hands on something that somebody dropped off for you, and they catch you. What do? Come on. There's people in this room been in treatment. Absolutely. Where are you going to go? Yeah. What are we doing? Because the most of the people that are struggling with are young, right? We're going to send a 20-something-year-old back to the street because, they've got to find their bottom. Really? And guys, I can't live with that anymore. I can't. And I'll call it out every single time. When we get somebody that drags themselves in and asks for help, we got to meet them where they are, no matter what. Period. That's it. That's it. All right? And there are consequences. There's consequences all our past. Y'all know it. And we have to own those. All right? And we have to move forward. But we've got to stop approaching addiction like we always have. Because the treatment world out there is a crapshoot. And there are people that prey on people who are in treatment and recovery housing and all this stuff. And they paint it to be one thing, and they're taking your money. And we got to stop that. Right? We got to set up a system of care that I walked into. And that's what I want to show you here. So I call this talk Turtle on a Fence Post. And thanks to Mike, I'm glad I got here early and heard you, because I would have repeated most of what you did. A little bit different because I don't use words on my slides. But other than that, same thing, same stuff. You did a great job, by the way. So I call this Turtle on a Fence Post. And so there's So I'm a Tennessee boy, and I like to use things from Tennessee. So anybody know who Alex Haley is? I know some gray-hairs in here know who Alex Haley is, right? Wrote the book Roots. It was a TV series in the late 1970s. And Alex Haley is actually a Tennessean. He lived in Norris, Tennessee, which is in East Tennessee, but his family and enslaved ancestors of Alex Haley's are actually from West Tennessee. But Alex Haley talks about a turtle on a fence post. And he said, turtle on a fence post. When you see a turtle on a fence post, it had some help getting there. All right? I mean, that turtle did not climb that fence post. And I think of recovery like that. People ask me about myself and say, well, how did you get where you are? I'm a turtle on a fence post. Guys, I got where I am because there's a bunch of people out there that helped me. And so when I go around and I talk about addiction and I talk about recovery, the opposite of addiction is not recovery. The opposite of addiction is community and relationship. And guys, these young folks and even older folks that are struggling with addiction, we got to meet them where they are, no matter what, many times as it takes. And we've got to help them, right? We've got to connect with them. We got to help them deal with the things, and we got to use any means necessary. I am a harm reduction guy, big time. Why? Because I ain't figured out how to treat dead people. All right, when I figure out how to treat dead people, then I will no longer be a harm reductionist. But until then, I'm a harm reductionist. If it takes medication to keep my patient alive, then I'm going to use medication to keep my patient alive. And I don't care what that medication is. I tell people all the time, if you told me that people did a better job of getting into recovery if you rubbed chicken crap across their upper lip, I would open up a clinic and we would rub chicken crap across the upper lip. We would. Right? We'll do anything that we need to do. So it starts with keeping people alive. And the longer we keep them alive, and Michael talked about this, the brain starts to recover. It starts to gain insight. It starts to gain judgment. It starts to gain empathy. And now we can go to work on those underlying drivers of addiction, right? And the big one is childhood trauma. And so I got a group of ladies down here in front of me that keep catching my eye, all right? And I'm connecting with several of them because I know they know what I'm talking about. We're talking about physical, sexual, and emotional abuse, right? And when we start going after that, and we start helping people with it, because that is my story, right? I come from a long line of people with addiction, so I got genetics, right? 4 of my cousins died before they were 40 years old, secondary to their addiction. So my DNA is my DNA. That's the first factor. The second factor is childhood trauma. I grew up with an abusive mom with untreated bipolar disorder who liked benzos. All right, very unpredictable. She beat me and my sister, not spankings, beatings. You name the weapon of choice. I promise you that me and my sister have faced it. And then lastly, I had an uncle that sexually abused me. Started with molestation, ended with rape when I was younger. All right, and so I'm going to put all that behind me. When I was a kid, I pulled myself up by my bootstraps. I made it all the way through med school. Guess what? None of that stuff went away. And when I found the opioid the first time, all that stuff went away because I thought it cured my anxiety, my depression, stuff I'd battled my whole life. That's just the deal. And then I didn't realize I needed more and more for less and less effect over time, and it damn near killed me. You all know the story from there. But until we take the approach that we're going to help people to this degree, then I don't know how much better we're going to get, because medications like Suboxone and methadone, they keep people alive, 70% mortality benefit, and I'm going to use it every single time if it comes down to keeping somebody alive. I just am. I mean, I'm not going to let them die. But the truth is it doesn't help them with the underlying issues. And so I see this because I got world-class help with my sexual trauma later on in my recovery, because I've been in recovery for, 10 years and doing fine until I started having flashback symptoms from the sexual assaults. All right, and I wound up on the edge of a bed with a 44, no, it was a 44, it was a 45 pointed at my skull. All right, with the hammer back. I fully intended on pulling the trigger, and I remembered from recovery, asked for help. And I asked for help, and I got to go to a place I drove myself to, pulled into the parking lot, said I need help. It's called Onsite. It's in Cumberland Furnace, Tennessee, which is, believe it, a little bit north of Dixon. And I got world-class trauma help there. Unbelievable. Bobby Chapman and those guys out there are ungodly. The problem is it's $35,000 a month. How do my girls get that? Because I treat pregnant girls, and I'm going to introduce you to one here in a minute. Her name's Brooke. And I think it's almost worse for me sometimes knowing that exists, because it's a pipe dream for most people. I had the money to be able to afford that. Most of my patients don't have that. Most of my patients don't have a job. Most of my patients can't get a job because somebody hung a felony on them because they had too much dope on them at one time, and they got them for intent to resell. Now they're wondering why they can't stay out of jail because they can't get a job. Really? So we have to take a look at our system of care. So that's the longest lead in to a talk you'll ever see. So get back to the turtle on the fence post. This is a systems issue. Sorry, I'm not sure where I am. 107,622. What is that? Anybody know? It's the number of overdose deaths from 2021. 107,622. So let's put that into numbers we can understand a little bit. 747, I think, outside of maybe the 777, is the biggest commercial aircraft that flies in the United States today. 107,622 is equivalent to a loaded 747 airplane crashing and burning and killing everybody on board every 36 hours around the clock for a whole year. And I dare say if we had a 747 going down and killing everybody on board every 36 hours, there wouldn't be anybody in this room get on an airplane. All right, I'm scared to get on them. We ain't had a crash in 20 years. Still scares me. All right. So when you talk about that number, it's massive and it's huge. And there are people that are sitting in this room tonight that have lost their children to drug overdoses. All right, and most of them are silent. And you never know about it. If this was any other disease, there would be people marching in the street, guarantee it. Right? We need help with this, but there's not. It's because of the stigma associated with it. I used to get mad at my Sunday school class back in East Tennessee because we'd sit around during Sunday school and pray that somebody sold a piece of property. And that really doesn't bother me, but that same person had a kid that was struggling, and we all knew it, and it was in the newspaper. Nobody said a word, and we put on our fancy clothes and drove our car and came there and left. We never talked about it, and it'll never get better doing that, guys. So these kids die in isolation. They don't die in a fiery plane crash that kills 300 other people. They die in their bedrooms. They die in hotel rooms. They die on the street. They die alone. And if we go back and we look at their deaths, the system touched them about 30 or 40 times in the year leading up to that death. We missed them in jails. We missed them in prisons. We missed them in hospital EDs after they overdosed. We missed them in family medicine offices. We missed them repeatedly, time and time again. And then we're shocked when they overdose, right? And I'm telling you, that's the system that we have. Now, I love that quote. It says, every system is designed perfectly to get the results that it gets. The system of care and treatment that we have in the United States and the state of Tennessee is designed perfectly to get that number. I have proof because there's the number. Okay. How many Tennesseans did we lose to overdose death in 2021? Anybody know? 3,033. Okay. And there's no way that number is right. The number is definitely low. Right. But 3,033. So I moved to Nashville in 2015. I went to work for Marie Williams and Governor Bill Haslam at the time. And when I went around talking to her, I met they weren't ropes then. We had lifeliners, but now we got ropes. So that's where I met all those guys. And the number that we used in 2015 for overdose deaths, anybody know what it was? 1,011. 2015, 7 years ago, now it's 3,033. That's exactly 3 times more, right? And I'm telling you the number is low. So this problem is getting worse, and it's being driven by illicit fentanyl. And here's the other thing I want to say about fentanyl. Anybody know what a CAL score is? Okay, right. So you know what it is, right? So CAL score is called a clinical opioid withdrawal scale. Okay, it is a measurement from goose flesh to upset stomach to aches and pains to blood pressure to pulse. It tells you how dope sick you are. So when I walked into detox unit at Vanderbilt University on July 8th, 2004, by the way, when I got to the treatment center, they said, you're going to need to go to detox. And I was like, what's detox? I had no idea. I'm a medical doctor. I'm board certified in internal medicine. I did not know what detox was. How is that possible? So I walk into detox and they did my CAL score. My CAL score was a 12. And I thought I was dying. I sweated through 9 T-shirts that first night. The psych tech who took care of me that night was a former basketball player at Vanderbilt. His name was Darius Kulabay. I hope to meet him again one of these days. He's 7'2". So I'm laying there shaking, withdrawing, thinking I'm seeing things, and I got a 7'2" monster taking care of me. It took me like 2 weeks to figure out the dude was really real. And he was great, and I love him for the care he took care of me. But I sweated through 9 T-shirts the first night. Guys, fentanyl is so much more powerful. Kids today have such higher tolerances, things that I didn't see 5 years ago, things I definitely didn't see 10 years ago. So kids that I get who in withdrawal, their CAL score is not 12, it's 35. Right? They're laying in my office floor, curled up like a little baby, vomiting, right? Bony aches and pains so bad they can't move, freezing to death, burning up, all at the same time. 1 minute they can't go to the bathroom, the next minute they can't hold their bowels. I have never seen anything like this. All right, and I'm not an alarmist, but I can tell you that I never saw it coming, and I never dreamed it would be as bad as it is. Fentanyl has changed the ballgame. Now, here's the worst part. There are worse fentanyls that we're starting to see in Tennessee. Okay, there's a whole new class of drugs out there called the nitazines, and I can't even pronounce some of them, but they're even more powerful than fentanyl. All right, and they keep showing up and stuff. So your kids go to a party, and I'm not condoning anything, but when I was in high school, we drank some beer and we smoked some weed. Okay, and I'm not condoning it, but we didn't die. Right, we didn't die. Now you go out and you don't even have to be in addiction. You can experiment one time and die right then. Right, and that's where we are. So I agree with what Michael was saying. We have to be open to talk to our kids about it. So our system of care we have right now is designed to get us this. And I'm going to show you the 2 systems that we have. So I have an OTP in Cocke County, Tennessee, second poorest county in the state. If those of you don't know where Cocke County is, if you go up I-40 and you pass Gatlinburg, all right, and Pigeon Forge on your right, and you stay on I-40 and you're headed over into North Carolina, into the mountains, the last county you pass through is Cocke County. Now, Cocke County is a notorious county. It's known for fighting roosters and moonshine. Okay, matter of fact, the TV show Moonshiners, the main moonshiner on there, Popcorn Sutton, was from Cocke County. So that's Cocke County, just unbelievably poor. The population of the county has a very low graduation rate from high school, a very low rate of people with 4-year college degrees. And so I have a clinic there, an OTP. An OTP is a methadone clinic. I hate methadone. It's ungodly long-acting. It has 1.5 million drug interactions. It's ungodly hard to dose, and it saves people's lives. All right. And I told you, if it's going to help people, then we do it. The reason I put a methadone clinic there is I got a judge in the 4th Judicial District up there named Dwayne Sloan, and he wanted to be able to offer all medication to his patients or his clients who were in jail, who were incarcerated, and who were in drug court. And guys, that's a unicorn, because even in Williamson County, you don't have that. I have patients that come here, they get picked up on an old warrant, they're doing fine on medication, they get put in jail to get automatically detoxed the second day you walk in that jail. And somebody in this county's got to stop that. Okay, because at some point they're going to get sued, okay? But the real thing is that when they get out of jail, their risk of overdose and dying is about 40 times higher than a normal person. And so they get out of jail after 2 weeks and they die, and they don't deserve to die. And so we got to take a look at our policies there. So I got this patient. She has an 11-year-old son. She's 31 years old. She does not have custody of her son, nor does she need it. I don't support that right now. She already has a scar from here to here. Why do people have scars from here to here? Open heart surgery. She's in her early 30s, so she's already had open heart surgery. She's 31 years old. She used intravenous heroin. She got endocarditis. She goes into a large academic institution in Knoxville, Tennessee, which I will leave nameless. They operate on her. They replace her heart valve, and they send her out of the hospital. What was her diagnosis when she left the hospital? What's going to be on her diagnosis sheet is going to be infective endocarditis, status post-mitral valve replacement, and I'm telling you that's a horse crap diagnosis. What's her diagnosis? Intravenous drug use. That's her diagnosis. And they sent her out of that hospital with a $150,000 heart valve and did not address her underlying addiction. How long do you think it took her to stick a needle back in her arm? 1 day. It took her 1 day. And people look at that and go, how could that be? You were just in the hospital. They replaced your heart valve. I don't care. I could overdose and turn around and use in 20 minutes. You don't understand addiction. When you understand addiction and you understand that you lose access to the frontal lobe of your brain during addiction, and if you don't have this thing out here, you're going to die. Guess what? You're going to get that thing out there, and it ain't going to matter. It's not going to matter that you're pregnant. It's not going to matter that you've got kids waiting on you at home. Now, when you get this, now you can do all that stuff. Right? That's the reality of addiction, and that's what we have to understand. So she goes right back out, puts the needle back in her arm, goes right back to using. When I got her, she was using 5 to 6 grams of heroin and fentanyl per day. Per day. All right? Her Cal score was one of the highest. I've never seen a 37 before. Matter of fact, when my nurses brought it to me, I thought they messed up, so I went back and did it myself. I was like, no, that's what it is. And it took us forever to get her under control. And I'd had her for 2 weeks, and she comes in, and she says, I want to show you my leg. Now, keep in mind, I've known her for 2 weeks. She pulls her pant leg up, and this is what I see. That's her leg. She's injecting into this. This needs to be in the hospital receiving antibiotics. I said, honey, you need to be in the hospital getting antibiotics. She goes, well, I was. She said, I was getting antibiotics, and so she's shooting that much heroin and fentanyl. What happens to her after she's been in the hospital for about a day, day and a half? What happens to her? Come on, she gets dope sick. She starts going into withdrawals. And those of you who've been in withdrawals know what I'm about to say is true. You are not a happy camper. You are not going to be the best patient in the world. All they had to do was treat her withdrawals. It's very easy. Right? I'd have given her Suboxone, and she'd have been fine in 20 minutes. But they didn't do that because they don't believe in that. So they're doing all this other things. And finally, they just kick her out. They kicked her out with that. I said, honey, you need to be on antibiotics. She goes, well, I am. I said, well, bring him in. So she brought him in, and I said, what are you on? She said, Clinda something. I thought, okay, clindamycin. Not bad, not a bad choice. Bring it in. She brought it in the next day, and she was on clindamycin. It was in a blue box, and it had fish on it. It was for guppies. She had Googled skin infection. She had Googled antibiotic for skin infection. She had figured out she could buy the antibiotic at the pet food store. We live in the United States of America, the richest country in the world, and it's not anywhere close. And this is the health care that we have for a 31-year-old mom with an 11-year-old son. All right, luckily for us, we have Walmart, and we have the $4 antibiotic list at Walmart. It took us about 8 weeks, and this cleared up. And I will tell you, I still have her. This is over 2 years ago. I still have her. And a couple of months ago, she got her second day of supervised visitation with her child. Okay? That's a good thing, right? That's a good thing. She doesn't need her child back yet. She's not ready for that. But these are steps, guys. These are harm reductions. People say, oh, she's not in recovery. She's on medication. Oh, come on. She's in recovery. You're telling me if you're getting your life back and you're not running from the cops to the blue lights and you're not sticking a needle in your arm and you've got a job and you're bringing money home and you can afford apartments and Christmas presents, that's recovery, guys. Recovery doesn't say anything. I've seen 1 million definitions of recovery. Not a damn one of them say anything about any other medication. Not one. Yet we've got people out there that'll run these kids off because they'll say, oh, you're not in real recovery. Me, I've told you, I'm cynical. I want to look on your computer hard drive, okay? That's me. All right, and I told you I got stuff to work on. So this is a good outcome. It's headed in that direction. She doesn't need custody of her kids back, but she's moving in that direction. Sorry, I'm having trouble here. This is my friend Brooke Sargent. When I left the state, I wanted to start a program for pregnant women because do you know how pregnant women are treated in our country who have substance use disorder? Places won't take them. What if they go in there and they find out they're pregnant after they get there? What do they do? Kick them out or try to put them in jail. Actually, we got that law repealed, so don't let anybody try to do that to you. But used to in Tennessee, if we found out you were pregnant and you were using, we took your kid and put you in jail. It's called the fetal assault law. That wasn't exactly what it said, but that's how our girls interpret it, so we might as well have said that. So I love taking care of pregnant women. They're why I get out of bed in the morning. because these are the most resilient, most awesome women I've ever met in my life. So, and I still do it. And I'm not an OBGYN. I didn't say I wanted to deliver their babies. All right, I hate that process. Bad. All right. So this is my friend Brooke Sargent. Brooke is the single toughest patient that I ever had in my life. Brooke is a certified welder. I knew Brooke for 2 weeks before she called me anything other than MFer. And she wasn't using the initials, okay, just so you know. So Brooke is living in Ohio. She is shooting heroin and fentanyl. And by the way, a lot of people won't go and test it and say this has fentanyl in it, I'm not going to use it. They're going to test it and say this has fentanyl in it, therefore I want it. And we have to understand that, right? Doesn't make sense to me and you because it can kill you, but that's not what's going through their head, okay? So fentanyl test strips actually have a downside to them. So if I'm a heroin dealer and I'm living here in Williamson County and y'all got them here, okay, and I've got heroin that ain't got any fentanyl in it, and they're testing me and says, well, your stuff doesn't have fentanyl in it, his does, I'm buying his, so now as a dope dealer, I'm going to get fentanyl in mine. So there is downsides to fentanyl test strips, okay? I'm a fan of them. We need to give them out. I agree, but there's unintended consequences for everything, okay? Methamphetamine. When you stop using methamphetamine, you don't get dope sick. It doesn't cause dependence. Okay, but most methamphetamine now in our state and all across the country is adulterated with fentanyl. If you take fentanyl and methamphetamine and you stop using it, you're going to get dope sick because you've been using the fentanyl even though you may not know it. Why would you do that? The dope dealer wants a repeat visit, right? And fentanyl's dirt cheap. It's ungodly cheap. You can order it on the internet. All right, it is ungodly cheap. So now you're dope sick, you got to come back. Meth will not cause a physiologic dependence. You'll feel bad when you stop using it, but you won't be dope sick. So you have to understand some of these things about substance use disorder. And everything I learned about drugs, I learned from dope dealers. Almost everything I learned, because they're the smartest ones about it. So Brooke is shooting heroin and fentanyl, and she finds out she's 8 weeks pregnant. She comes home and tells her mom. They get on the computer, and they Google places that will take pregnant women, and my name popped up in Murfreesboro. And they called me, and I said, yeah, I'll bring her. And she put her in the car, and she took this picture of Brooke right before they come. It's about a 7-hour drive. So this is about 7 hours before I met Brooke. So you see these? All right, what's that? All right, it's actually not. All right, it's actually pick marks from methamphetamine use. You got to remember, methamphetamine is made from stuff you find in the cleaning section of Lowe's. Okay, and it gets deposited under skin. It itches. People pick at it. So that's actually methamphetamine, but she was using a mixture of both. I see this picture of Brooke, and this is not the Brooke I remember. The good thing about pregnant women is, where am I at? There we go. Good thing about pregnant women is you can scare the heck out of insurance companies with them. So I scared the heck out of an insurance company for Brooke, and so this is her. I love this picture of her. We had her in a sober living facility at this point. She had TennCare. She had insurance. She wasn't paying anything at all to see her doctor, who was me. She had stopped calling me MFer. So now she at least called me Steve. Which I was fine with, but I love this picture of Brooke because it just captures her. She's got a mean streak, and I love the look in her eye here. But she was getting better. She had the things that she needed. She had services through Tennessee Medicaid, and she was on the path to recovery. Well, this is her mom, Angie. You can tell that's her mom, right? They kind of look like they budded off of each other asexually. But look at Brooke there. I mean, you know what I get addicted to? This. I get to see this to less than 9 months later. Well, dadgummit. Yeah, that, right? So So the previous picture was right before they were going into the delivery suite. And so Brooke and Angie, and now you meet Ava. So this is the first picture that Brooke had formerly made with Ava. Look at Brooke. Brooke is a dime. Y'all know what a dime is? It's a 10, right? I got Urban Dictionary. All right, so Brooke is a dime, and she loved Ava, but she wanted to go back to Ohio where she was from, and I didn't want her to go. Why don't I want her to go there? Because there's something there called a baby daddy, and the baby daddy's still using. Okay, the first time I heard the term baby daddy, I had no idea what it was, and I was too embarrassed to ask, and I already told you, I knew about Urban Dictionary, so I looked it up. Right, so I know what a baby daddy is. So baby daddy's there. Brooke doesn't have the support system that she needs back in Ohio. She's got a mom that'll take care of her, but he's there as well. She doesn't have a doctor that'll take her Medicaid. Her doctor takes $125, $150 a week, not a month, a week, cash from her, simply to write her a prescription. Does nothing with her mental health issues, does nothing to address Brooke's underlying trauma. And I promise you, her trauma history is as long as my leg in my Sunday school class don't want to hear it, okay? Because it's just reality, and that's Brooke's past. And so Brooke starts to struggle. Okay, she starts to run into issues. She's a certified welder. Certified welders should make about $40-45 an hour, bottom, okay? She's got a felony. She can't get a job as a certified welder. She works at a convenience mart, gives all of her money to the doctor to write her script every week. That's the system of care that Brooke stepped into. So let's pause the story right there and let's go back a few years to 1999. Now, I realize it's going to be hard, but that's me. And I really wished that I still had that, just so you know. That's why I have a hat on, in case you're wondering. So that's graduation from med school. I went from a little boy in Jonesboro, Tennessee, that never had anybody in his family graduate college, and I got all the way through med school. That's my wife, Karen. That's my best friend in med school, Mike, who's a retina surgeon. That's his wife, Michelle. That's the day we graduated med school. My first day or second day of med school, I always had a problem with alcohol. I'd never been able to drink successfully. I didn't keep it at home, but when I started, I couldn't stop. Our second day of med school, my classmates elected me their class president. I couldn't let them see me drink. I didn't want to embarrass them. And so I didn't drink all the way through med school, no drugs, nothing. And they used to get on me and laugh all the time. I said, you don't want to see me like that. And I for certain didn't want to embarrass them. But after this day, guess what? They all left. And I started drinking, and right after that, not long, within 2 weeks, and then I discovered opioids within a year of when this picture was taken. Had my whole life in front of me. Young doctor, there's my medical degree. I'm living in a house that when I was a little boy, my parents used to drive us through that neighborhood and look at those houses at Christmas time because that's the rich people's Christmas lights. That's what we did. I live in one of those houses. I had everything right in front of me that I ever dreamed of, yet I was getting ready to pick up opioids. Getting ready to pick up opioids because I'd never felt comfortable in my own skin. I'd always felt out of place, like I didn't belong. I wasn't good enough. I had a personality, and I used that personality to keep people out here. You can do that. You can be out front, very, very outgoing, and keep people out here, and that's what I did my entire life. This is me and Karen. That's my son, Heath. That's my daughter, Haley. Obviously, we're Tennessee fans, unfortunately. It's pretty hard to be. But at any rate, we are. We're going to a Tennessee game that day. That's out on Boone Lake in the Tri-Cities. One of my med school professors took that picture. It looks like the perfect young American family, right? In my pocket are at least 10 80-milligram Oxycontins. Yeah, right there. You can almost see the bulge. Right, so that's what people don't know when I look at those pictures, and that's what I see. Looks great here, but I know what's right there. I love kids. I want to be around kids. I have 2 children. You've seen Heath and Haley. They're grown now. He's 28, Haley's 25. Both of them are married, and I am yet to have a grandkid, and I'm salty. And Karen says if I don't stop mentioning, I'm never going to get one, so I'm really working on it. But these are all of my kids at Disney World. So that's me in the middle, my son Heath, my nephew, my goddaughter Paxton, my other goddaughter Piper, my daughter Haley, and then my niece Jameson. And I'm right in the middle of them. It's the end of a long day at Disney, and I have played with them all day long. I told God not long after this picture was made, if he got me out of there, I'd never go back. I've been back numerous times. I didn't follow through on that. It's a beautiful picture, except I got 2 pockets full of pills that I used all day long. Right? Nobody sees that. Nobody sees that. I'm ducking in the bathroom at Disney World, crushing it on the freaking counter and snorting it in Disney World, right? And I'm a young doctor back in East Tennessee. So that's where my life was. I couldn't let anybody know that. Luckily, we left Disney World and we went on a Disney cruise. First time I'd ever been on a cruise ship. And I actually had to have Karen take this picture down in our house. It was in our house until about a year ago. But we took this picture, and I miscounted my pills. I didn't have enough pills to finish the trip. And so I'm addicted to OxyContin and Xanax, and I'm out in the middle of the ocean, and I ain't got any pills. Guess what's getting ready to happen to me? I'm getting ready to get dope sick. And if you look at my forehead there, I am dope sick. And I weighed about 170-some pounds, and I look at this picture hanging over the hearth in our house, and I finally had her take it down because she doesn't know the backside of this. Now, I'm going to tell you this. We're out floating around in the Caribbean, and I had no idea, but guess what? In the Caribbean, when you go into port, they don't have a DEA, and they don't have drug laws, and they sell codeine and Vicodin over the counter like Tylenol. And I walked in that pharmacy and saw that, and I was like, oh, my God, thank you. I thought God had smiled on me. That's where my mind was. God didn't have anything to do with that. And so that was the only thing that kept me from being dope sick, but I had to have this picture taken down. So I'm a young doctor. I've got my whole life in front of me. I've got this secret nobody knows about. And then finally, I crash and burn. The difference between me and Brooke, I just explained the system that Brooke got set up in, right? She had an insurance company determining her length of stay. She went back to a place where the doctors didn't take her insurance, and she's having to pay cash. She had no social support. She had no job because she had a felony because she couldn't get a job doing what she normally does. She had a baby daddy who's still using himself. What did I have? I had an MD degree, a medical license, which I can tell you is a very valuable thing, right? I can make a living. I had a wife that doesn't use. I had a supportive family. I had an education. I had a house. I had cars. I was gone for 95 days of high-quality treatment at CPE with Chip Dodd. I got the world's best addiction care. After I got out of treatment, I had 5 years of aftercare and follow-up from a place right here in Brentwood called the Tennessee Medical Foundation. A guy named Roland Gray was the medical director, and I kept my job the whole time. So I got back to Johnson City. I went back to teaching, and my career started to go up. I became residency program director. So it means I ran the residency program for all of internal medicine. Then I got a job at the VA, and I was over every training program at our VA, and there was 26 of them. And then I got to be the chief of medicine at our VA. So I had 140 some doctors working under me. And then I got to be the chief of staff for the hospital. So I was the top doc in the whole hospital. All right, all with this background. I'm a turtle on a fence post. Look at the system that I stepped into. The system that I stepped into in Nashville, Tennessee on July 8th, 2004 was designed for me to succeed. How come it's designed for me to succeed? Because you all paid for me. I'm expensive. My medical school tuition was a certain amount of money, but most of it was actually paid by you guys. You guys buy goods and services in Tennessee, and you buy lottery tickets. Okay, so your lottery tickets and your sales tax funded my medical education. It's expensive to kick me to the curbside because it takes a lot of money to make me. And I did not get kicked to the curbside for that reason. And I stepped into a system of care that was designed for me to be successful. What percentage of doctors that have the problem that I have at 5 years are off of everything and back in their jobs? Anybody know? It's about 95%. 9-5, right? We don't bat that with strep throat. What is it for everybody else? What is it if I take somebody off the street, put them in the system that they get to walk into and measure them at 5 years? What percentage of them are off of everything and back in their jobs? It's about 8. It's about 8. So I think that's a good mark for the number of people who just get sick and tired of being sick and tired. I think it's about 8%. Okay? Guys, the system is set up that way. You don't get what I get. You don't get what a movie star gets or what a professional athlete gets. You get what your insurance company tells you get. And we bring kids in, we detox them, and we send them out to die. And we do it time and time and time again, and we do it right here in Williamson County. Guarantee it. Guarantee it. And this is what I rail against. So look at what's happened in my life. I moved to Nashville. I become the drug czar for the state of Tennessee. I get to live this life. And then a few years ago, that's Governor Bill Lee. Do you all know what this is? This is the Tennessee Medical Board, okay? We oversee the doctors in the state, and that bald-headed guy right there is me. I should be in front of the Tennessee Medical Board, not on it, right? And I'm the vice president of the Tennessee Medical Board today. This is the system that I walked into, that I got to succeed. It was designed for me to be successful. This is the system that we have to have for every citizen of the state of Tennessee. Because had I not been a doctor, you know how many scripts I've busted? Hundreds, right? At least 400. And each one of those is a 8-year Class D felony, so 8 times. I should be in jail for 320 years. Okay? And I'm not at jail. Matter of fact, I've been an expert witness for the DEA and the federal government for 15 years. Okay? Look at the system that I stepped into. I didn't get a felony hung on me because I was in possession of too much drugs. I can assure you I was always in possession of too much drugs. Just never got caught or never had anybody look. Okay? That's the only difference. Okay. Sorry. I'm not sure. So what happened to Brooke? So Brooke starts to slip. She has a relapse. She gets put in jail. They detoxed her forcefully in jail, took her off for all of her medication, took her off of all of her mental health medication. And when they let her go after a month, after she was off everything, they didn't set her up with an appointment for anybody for mental health or anybody for addiction. And on December 20th, which I think was a Sunday morning, my phone rang really early. And I looked down and it was Angie, and I knew that wasn't going to be good. And she said, "Hey, Steve, I can't wake Brooke up, and she's cold in her bed." Brooke died of an acute heroin and fentanyl overdose. This is a preventable death. 107-622, this is one of them. And this one's preventable. It was preventable. It's a system issue, guys, and we've got to address the system. This is the thing. It's why I'm down here tonight. I don't know what time it is. I'm sure I'm past my time. All right, I'm here because of this. This is the stuff that's got to stop. And we got to have people that are outraged by this, because this pisses me off. Because you'll say, okay, well, that's the end of the story. Brooke died. Think so? Who's that? That's Ava. I got this picture not long ago. Ava's potty training. She's almost 2 now. Here's her little potty. She appears to be very proud of whatever happened here. Ava now has an ACEs score. What's ACEs? Adverse Childhood Experiences. She'll never know her mom. She'll never know how tough Brooke was. She's being raised by Angie. Do you know how many grandparents in the state of Tennessee we have raising their grandchildren? A boatload. All right. And then we got some of them that can't even do it because they can't do it anymore because they're too old, and they're overwhelming our foster care and DCS systems. All right. This is what we're faced with. We have a systems problem, and we got to change our approach, or it's going to keep getting worse, because Ava has genetics, right? Her mom and dad both with addiction, and she's got a trauma history. If we don't intervene on Ava, what are the chances she's in the system at 14 or 15? It's pretty high. All right, we know how to do this. We just have to have the courage to step into it and do it. Compare that obituary to this picture. This is my family. That's my son Heath, my now daughter-in-law Laura. She was Heath's girlfriend then. That's Karen. That's me. I still was putting up the fight there. I was trying. I want to concentrate on this side of the picture. Anybody know what that is in the background? It's Florence, Italy. All right, I never dreamed as a little boy growing up in Jonesboro I'd go to Florence, Italy. And I remember the day we took that picture, and you know what a dream it was for me to get to take my family. But right there, Haley, that's my daughter Haley. That's where all my money goes. It really is. Every day of Haley's life, I went into her bedroom, and I dug down into her covers, and I kissed her on the head, and I told her how much she belonged and how much she mattered. Every morning of her life. I did a lot of things wrong as a dad. I did not miss that one. I got into recovery when my kids were small. They've never seen me drink a beer. They've never seen me take a pill. All right? They don't, to them, some of these stories, I mean, they just blow their mind. But they're all true, I promise you. So that's my daughter, Haley. Now, the men in the room, and I'm a misogynist, and I'm a firm believer in the old double standard, so, you know, file a complaint. All right? So the men in the room know this. When you have a little girl, and I had Heath, right? And Heath's my boy, and I loved him, but when it was time for him to get out of the house, I mean, hell, he needed to go. All right? Haley was a different story altogether. As a matter of fact, I made an offer to pay for everything the rest of her life if she'd just stay in her room. Everything. You'll never have to work a day. I'll pay for it all. She didn't take me up on it. So every dad in the room knows that when you have a little girl, at some point in her life, somebody's going to come along and take her. All right, Steve Martin's in a great movie called Father of the Bride, and I promise you it's spot on. Okay, so you know that. And so I knew that Haley's entire life and very close to Haley. So when she was a junior in high school, she brought this thing right here home. They were going to the senior prom. He was a senior and she was a junior. That was their first date. I was sitting out on the front porch waiting on him because I was considering several things. And I could have spent time in jail for a few of them. So Haley was inside getting ready, and so I talked to that kid. His name's Sterling. I talked to him for about 5 minutes. I walked into my house where my wife was. I said, Karen, I think I just met our son-in-law. She's like, oh, come on, Steve. This is their first date. They're juniors and seniors in high school. 6 years later, I'm standing at the end of a long aisle, and there's a dude with a Bible on the other end, and Haley is on my right arm, and he's standing up front. All right. So it was a day I'd been dreading Haley's entire life. And it was awful. I was a wreck, and Haley is on my right arm. And right before I walked her down the aisle, she leaned her head over on my shoulder. She should have apologized to me for how much it cost, but she didn't do that. She leaned her head over on my shoulder, and she said, "Daddy, you're the first man I ever loved. Thank you for everything you ever did for me." So that day was good in a hurry, right? That doesn't get much better than that. And my kids know that part of the story. They don't know the part I'm getting ready to tell you. I'm a gratitude guy. I'm an optimist guy. I think we're going to win. We're not going to bring people back from the dead, but I think we're going to win. I think we're going to turn the corner. I think we're going to change the narrative on addiction, and I think we're going to win. Okay, I am an eternal optimist, and I always look for gratitude. When I'm having a bad day, and I had a bad day early this morning, I got in a funk, and I immediately had to go to gratitude. What are the things I'm grateful for in my life? Okay, here's what I get to do the rest of the day, and part of it was you guys. I get to come and talk to you guys tonight, which I love to do. So I'm standing there, and she's just told me that, and I know that in our program that night, I'm Stephen Lloyd, father of the bride. I'm not Stephen Lloyd, parentheses, in 2 dates, right? I'm still alive. I'm Stephen Lloyd, May 11th, 1967, Dash. I'm still a Dash. Karen hadn't married the pool boy, okay? He wasn't the one walking her down the aisle. It was me. My gratitude went up multiple notches from that. During the pandemic did some really good things. I know most of them are horrible, but it did some really good things. One, sports weren't on TV for about 6 weeks, okay? And so therefore we couldn't watch TV because we only watch sports. And so we ate dinner together. So we've got the dinner table, the family dinner table came back. It still exists at my house. We still do it now. So my kids were all living with me. Haley and Sterling are married, and Heath is getting married to Laura. So in April, when the whole state was shut down, we were downstairs. We had dinner ready. Heath comes down, sits down at the table, and he calls me Pops. He said, "Hey, Pops." He said, "Would you be the best man at my wedding?" Now, Heath played college baseball. He has 1 million buddies. Okay, he had 14 groomsmen. Okay, I was my son's best man. Daddies aren't asked to be best men who are absent. I wasn't absent. I stepped into it. I'm flawed. I made mistakes. Heath knows it. I heard him. He doesn't know I know this. So he got interviewed not long ago, and somebody asked him in the interview what the thing he admired most about his dad was. So I'm freaking out a little bit, okay? He said, "I love my dad's ability to get back up." I get back up. My hero when I was a kid was Muhammad Ali. And Ali said, "Ain't how many times you get knocked down, it's how many times you get back up." And so I get back up, guys. We got to give these kids an opportunity to get back up. Heath asked me to be the best man at his wedding. I tell you that story to compare it to Brooke. Brooke walked into a system that was designed for her to die, and her daughter will never know her. Stephen Lloyd, because he's got MD after his name, walks into a system that allows him to be the best man at his son's wedding and to walk his daughter down the aisle. 2 greatest things that ever happened to me in my life. And I'm telling you, the people out there who are in the Williamson County Jail right now for really nothing other than being addicted, this is what they want. And we got to change our system to make sure that they get the opportunities that I got. All right, with that said, I'm done. Okay. Thank you all.
Tonight, drive carefully. We've left resources for you on your chairs. And I do want to say that there are folks in our audience tonight who have lost loved ones due to fentanyl. For the Dreys, the Jessicas, the Zachs, may tonight be inspiration, and may we move forward in your name and do better, as Dr. Lloyd has said. Thank you again. Please stay in touch with all of us, and let us stay together and come together as a community and keep doing good work out there. Thank you.